Hello and welcome to Designing for Health. I'm Nordic's Chief Medical Officer, Dr. Craig Joseph. In this episode, I sit down with Dr. Bart Kaczmarek, a family physician in Ontario, Canada, who has built one of the most unconventional and efficient primary care practices I've ever encountered. By rethinking workflows, delegating work to the top of each member's license, redesigning clinic flow, and obsessing over details as small as who peels the Band-Aids, Bart cares for roughly 4,000 patients, sees 80 to 100 patients a day, maintains same-day access, and still works fewer than 25 hours a week. We explore what healthcare leaders and physician executives can learn from his approach, including team design, operational efficiency, practice layout, workflow automation, and why many healthcare organizations focus on technology before fixing broken processes. Whether you agree with all of Bart's ideas or not, his story is a fascinating case study in challenging assumptions about capacity, access, physician workload, and the future of ambulatory care. Let's plug in. Dr. Bart Kaczmarek. I said your name correctly.
You did. Yes, that doesn't happen too often. That was great.
You have coached me effectively. Dr. Kaczmarek, tell us where we are talking to you from today.
I'm right now in my family practice office in the Windsor, Ontario, Canada.
And so you speak Canadian, I assume?
Yes, fluently.
All right, that's good. That's good. I know a few words. I can say a few words. My mother was born in Toronto, so I have some Canadian expertise, but it's very minimal. I can mostly just say A, and so that doesn't help me a lot when I'm in Canada, but it's a little bit of something. So I'm very excited about this conversation. You and I met on LinkedIn, of all places. And I'm fascinated by your story. I'm fascinated by what you've done, both without technology, just kind of setting up how you set up your office and your thoughts about how to run a successful solo practice office. But also I'm excited about some of the technology that you've created and that you leverage. So why don't we start back at the beginning? Tell us about yourself, how you got to be a family practice doctor in Canada.
Yeah, so that's a interesting story. I was actually a resident in urology in Poland a long, long time ago, where I met my wife. She was a Canadian studying medicine in Poland. And surprisingly, I didn't meet her in the medical school. We met in a gym, so that was completely random.
Okay.
And then, we decided that we, should live together. And we decided where to go, and we decided let's go to kind of North America. And I came here, almost finished my residency back home, but not quite. So I had to restart my career, and I was looking how to get in what I knew, urology, and it was difficult. I didn't even realize that it was so difficult and challenging, much more challenging than back home. And at one point we were flying. She was a resident in Atlanta in family medicine herself. And we're flying back home to Detroit, which is, how you land often the closest to Windsor area. Then you cross the border. And I sat beside a pathologist from Henry Ford. We started chatting. And then he said, hey, you're looking for this? Maybe I'll get you in contact with someone. And then he contacted me with a urology, Dr. Craig Rogers, who is actually now a head of urology at Henry Ford Hospital. And he got me into like a fellowship, research fellowship, then 2 years of a clinical fellowship in urology. And then from there, I realized it's a long, long road before I would start residency again. So I switched to family medicine. And that's kind of how it started, that I find myself here. At the beginning, I have to say, I was quite disappointed that I am a family medicine doctor, not a urologist. Like my mind was set on this set. And it was hard to swallow. I felt like disappointing myself, everybody else. But now, actually, from the perspective of time, I'm actually grateful, because this is the specialty that allows me the most flexibility and the most control over what I do at work, how I work, and how I organize my work, which is kind of what brings us here together.
Yeah, that's a great story. Is your wife from the Windsor area? You said she's Canadian.
Yes, she's Canadian from Windsor area, and kind of came back to where her home area is.
Okay. Again, I was born in Detroit, and so I'm very aware of Windsor. I think when we were preparing for this episode, I I mentioned to you, which is something you already know, but most of our listeners probably won't know, Windsor is the one place, Detroit, going from Detroit to Windsor is the one place where you go south to get in from the United States to Canada. It's a weird kind of geographic oddity, but yeah, we think of Canada as always north of us, and Windsor is not, at least not north of Detroit. All right, so you were going to become a urologist. You almost became a urologist, but now you're a family practice doctor. You inherited an office. Like, how did you start practicing? Did you join a larger group, or did you just go right into being a solo practitioner?
So first, after my residency at Henry Ford Hospital, I became a staff doctor there at Henry Ford, one of the satellite locations. That was for about a year or 2 years. I was there, and then the pandemics came, and then I realized I actually wanted. It seemed like the doctors here in Canada had been more free and more. I've seen them all biking and hiking and talking about their lifestyle more, and I felt like something's missing. Why am I not doing it? Maybe it's grass is greener on the Canadian side. So that made me switch to Canada and try to first I started as a urgent care doctor because it's easy to get. You can find hire everywhere quickly, and then I took over a practice in a model that's called FO. It's more of like a capitation model. There's a little bit of, for those who don't know, a little bit of fee for service, like a 15% of regular fee for service, and the majority of income is from the capitation model. That's kind of how I started my Canadian family practice.
And is that pretty typical for Canada for primary care doctors, that it's mostly kind of capitated from this? Is it from the state or from the province?
Yes, I think it's becoming more and more popular. There's a clear push towards that model rather than fee for service. The clear fee for service is rather the least common, I would say. The pure capitation is one extreme, and there's something in the middle that has like half and half a little bit. You still have to do volumes. So there's three main. Actually, this is Ontario model. This is all can be different in different
Okay.
provinces, but yeah, capitation become more and more popular.
Okay. And so in your first office in Windsor, when you kind of went from urgent care to family practice, it was a pretty traditional office, right? Paper charts,
Oh yeah.
regular numbers of staff. Tell us how that was.
So here's the thing. I had the opportunity to take over this FO, which is the capitation fee model. After a doctor who wanted to retire, someone let me know. I quickly ran there, make sure because I don't lose that opportunity. And so the model was right, but then I walk in the building that looked like it's 1950s. The office was like 2 rooms with the carpet from, I think, at least 1950s unchanged and rubbed off. It really looked like a travel in time, like almost 100 years. And then to supplement the travel in time, there was the paper charts piling on the desks and everywhere. So it was kind of very traditional. I think less and less of this exists right now, but there was some computer to mainly, I think, submit billings only, but everything
Sure.
else was just paper, pure paper, and lots of those cabinets with drawers and all that. So that was my first experience. There was like 1,300 patients I took over from the retiring doctor, and there was one secretary taking care of everything, and she had it under control. But I think that was the top capacity of what that building, with that office, and what that single person could have ever done. This was like this engine, you press to the bottom and just keeps on making funny sounds, almost breaking. That's kind of what probably was the top capacity of the old doctor plus the secretary and the building.
So this doctor didn't have any nurses or medical assistants or anything?
No, he was solo.
Wow.
He dedicated his own one full day to follow his charts, to fill his gaps in paperwork, to review things. So I think Wednesday was his full day where he just sat all day from 9 till 4 or 5 and kept on writing gaps in his charting, pen work, and that's what his full day. Yeah.
Okay. And so you kind of decided to get new carpet, sounds like. Tell us about how you went about kind of modernizing not only the infrastructure and the physical plant, but also the way it functioned.
Yeah, so definitely I knew that paper charts. I actually had experience with paper charts in urgent care, and if the the story is very uncomplex and you just do one problem at a time, that's actually pretty good, decent way to manage things. But if family medicine is so complex that the coordination and looking back, as much as I okayed paper charts for urgent care, that just became just too complex and would never be a viable long-term expansion there. And I couldn't work from home if I wanted to because charts were in there. So in that environment, I realized right away that it's not something that can continue. And I got
Mm.
this popular EMR that's here. The group I joined had, so we had one server, and I bought what was it, one, two, three, four computers at the time. That was exciting, kind of very pioneer time. It's like you're going to conquer something in the you know someone that the human foot never set there. That was that feeling like you're discovering a map here a little bit, like restarting everything from scratch. Yeah, and then I didn't actually change the carpets. I moved to took over another doctor's practice while my EMR was
Ah.
already swinging. There was a same group doctor on the same floor in the office that had four patient rooms. Actually, there was he used two, and the other ones were storage. I took over his practice. Now I took over another 1,600 patients, so I was about close to 3,000. And I took over this doctor's practice and an office. And now I reorganized those two rooms to be in total four patient rooms, and I could use four rooms to be more efficient. That was my second step.
Okay, so you are sounding more and more like a surgeon to me now. You basically took two full practices and was like, yeah, we'll do that. Um, so how did you kind of take that leap from, well, okay, I think I can see all of these patients and manage their care over time, and it's not just the technology. So yes, you had an electronic health record, but it sounds like you've done a lot more. Like how did this evolve? Like, did you start with just, four rooms, and what kind of staff did you have? And I'm just interested in the evolution, how long it took you to figure out, oh, I could hire a lot more people and I can support them by seeing these patients. Explain that to us.
Yeah, that's exactly what kind of I eventually realized that you can make more money by hiring more staff to help you as long as you delegate things on the way. And that was my first experience. I initially hired someone because I realized I don't want to do blood pressure, health checks. I don't want to do simple reviews like everybody else is doing. It's a standard in medicine, but I always was feeling like, why am I doing it? Why is it on my plate? Like even when I worked at the Henry Ford, I felt like there was some medical assistant, but there was one for two doctors, and they seemed to be always somewhere else. And I couldn't reliably have her to do the standardized prepping for a room for me. So, and I realized that when I worked at the urgent care, there was a nurse who was like so helpful to me. She was like doing things for me out of her own kind of anticipation. And before I had my practice, I thought to myself, if I ever have my own practice, I'll hire her. And she became my first hire, actually.
Oh,
It happened. And so she was kind of open to doing things for me and being available and kind of crossing a little bit of a role of a nurse into other fields and doing more. And I realized this is when I realized it is quite possible. And in the first office, we had her help me prep patients. But then we realized we have capacity now with paper charts being on the side, with the biggest kind of concerns being already taken care of. Now I can have her just prepare all the patients for me and do simple prepping and maybe review prescriptions, refill things, start refilling prescription for me with guardrails. So I don't have to sit to something very simple like, I don't know, amlodipine refill for the next 3 months. That doesn't require me, I thought. So I can tell her if patient's been seen here within a year or 2 years, you can refill this and then I don't have to see it. So that's how things started, that we started using this delegation model, the nurse helping me out. And that's why I realized I can increase my capacity to a bigger clinic and double my patient roster. And we did, and it went pretty smoothly.
and so how did you get any feedback from patients that they were people concerned, I guess? Like if you had tried this at a traditional, you said you had worked at Henry Ford, which is a huge medical group, many hospitals in the Michigan area. If you had kind of proposed something like this, you would have been laughed out of the area, I think. But since you're a solo practitioner, you could do it. How did the patients respond?
It was, I think patients get used to anything you do at one point. At one point, a few people will be surprised. We kept on changing how we see patients for follow-ups, and we kept on like drastically having them do things differently as they remembered. And I realized that there is a lag of few months where you can just retrain your patients to accept that this is a new thing. And it's just consistency and the new behavior and just having some good explanation if they ask. But there was never really a concern. And when you say that, I'm thinking, I don't know. I don't know the reality in the U.S. right now. I've been out of U.S. medicine for a while, but in Ontario right now, a pharmacist can prescribe medication, including antibiotics, for things like UTIs and such. So that was unheard of, say, a year and a half ago. But now it's a reality, and you could say it's equally shocking. So if I'm seeing pharmacists taking care of UTI antibiotics for the patients, why wouldn't the nurse refill medications or have the same guardrailed protocol in the medical office with me not being gone forever and not being available, but me being available if there's any question? That's, I think, is the key here.
Yeah, what you're describing and what larger groups have done is created protocols, right? And
Mhm.
and just like you had said, hey, a nurse is not practicing medicine. A nurse is making a decision based on criteria that I've set out, which is, hey, has the patient been seen in the last year? Is the patient stable on their blood? Are they coming for their blood pressure checks? Is the medicine working? Then yeah, just go refill it. I don't want to know about it. I don't need to know about it. If they fail any of these measures, then now we have a situation and now I do need to be involved. And so having that protocol, again, you're not asking people to work above their license. You're asking them to work at the top of their license. And I love it. I'm a huge fan. And one of the things I see is oftentimes people think they need technology to solve
Mhm.
all of these problems. And no, they don't. You need some technology, as you pointed out. This wouldn't work with paper. However, or maybe it would, but it wouldn't work as efficiently or as
Mhm.
conveniently for you. You wouldn't be able to catch up on any paperwork that you wanted to do at home because, again, the charts are all centrally located in your office, but you're still able to kind of make it work with minimal technology. And I know you've been thinking about this, and this is kind of how we met each other, at least online. You've kind of come up with this framework called craft. Tell us a little bit about, why did you kind of come up with this? You've done videos to talk about it, which are pretty awesome, and we'll put some links into the at the end of the podcast for you. But yeah, tell us a little bit about craft.
Yes. Yes. So the craft was this idea because I was thinking, how can I make this thing that works for me reproducible? Right now, I am taking care of 4,000 patients. Right now, I'm working actually less than 25 hours a week, and I'm billing about 5 times average of Ontario family medicine doctors, with less work and quality metrics that are reflected in lower antibiotic use than average and higher screening rates than average family doctor in Ontario. So my quality metrics derived from this, I think they're at least above average with everything I do. And I wanted to show that this is not something that only worked for me, but this is something that should work for everyone. So I designed this. I was analyzed like back engineering what worked for me. How is it that things are working for me like this, and how could I show it to anyone that could reproduce that system in any of their practices that they are completely in charge of. So if you work for a huge system, you may have less leeway to do this. But if you're a solo practitioner, in Canada specifically, it's the most common model. That's something that you'll be able to do. So I figured out first, like, what would be the easiest things? Not the list of things, but what would be the stages? So the craft is the acronym for stages, 5 stages that can follow one another. So first one I thought was I call it C for clean, which is what can you do without any spending to increase your budget because of several things that can make you more money with very little effort. And one of them is, some of them we all do, but all of them together gave me the capacity to hire my first employee. And I
Mm.
wasn't, not only I wasn't losing money on it, but I was actually making money on every employee that I hire. My return on investment is 2.1 on every dollar I'm spending on my hired staff, and they just bring me money. So this is the way to kind of to do it. And so a few ideas from that list is that, build pre-visit mandatory kind of intake forms. So you don't have to ask the patient for, what are you here for? How long is your headache? Does it give you dizziness? Are you losing consciousness? All this will be taken care of before you walk in the room. And a lot of software now exists to send patients JavaScripted forms. And if you're still on paper charts, send them paper charts before they walk in the room. So you have everything kind of clarified. You could just copy this to your chart too. Then what works for me in my EMR is I build like the assessment and plan templates for that. It's one template that includes 5 most common assessment and plans. So I don't have to type it. If there's some of them only existing or one, I just delete the rest. But the most common defaults are there, which is kind of like, for a good example, is if I'm having someone with a cold or cough, the treatment is it most likely is going to be reassurance. So I just keep this as in a template, and if the cold comes, 99% is going to be reassurance. So I already have it written for that. Then use all those EMR shortcuts. You could, not just the basic ones, the advanced ones that can be helpful. I think the big thing that works for me is learning how to touch type. If you go online and learn how to type super quick, by 5 minutes a day for like 3 months, I believe you can get to the typing mastery that, I talk to patients and type if they talk to me. So I look at them and I type the note if I have to. So that kind of makes me really efficient. I moved a lot of follow-ups to phone visits, so I don't stack my days with just regular follow-up visits. You could just go up on the pricing of the fee-for-service things that you do in your office. So I wasn't an average price things for paperwork. I just went to the top. I doubled or tripled my fees for extra paperwork things, because we hate paperwork so much and then we charge so little for it. It's not a must, right? If someone needs paperwork, I want to feel that I'm not upset doing it. I feel, oh yeah, I'm doing it. It's not something I like, but hey, at least I get not $20 but $100 for it, and that's already a win here. Then what also works for me here is I advertise my services that are kind of extras. I have a TV in the waiting room, and I just advertise stuff that the patients may not know about. I may make money on it. So this is just use it by TV for $200, $300, and that's almost no cost. What else? I also practice binary decisions. Like, I don't try to not dwell too much in the room. That's a bit of a skill. If someone comes for this cough, then my thinking is it pneumonia or not? If it's pneumonia, I give them antibiotics. If it's not pneumonia, I do over-the-counter and reassurance. So I don't dwell on like, it was your runny nose for 3 days or 5 days. It doesn't look like pneumonia. You're going to get over-the-counter treatments or whatever you like. But if there's sounds like pneumonia, get antibiotics. So I don't spend time on things that are, to me, binary, either left or right, and that a lot of things get sorted out pretty quickly in the room. And that's most common things that are on the table for most of the doctors that could be done more efficiently and with higher satisfaction.
Okay. And are those, so those together are some of the things that you've done to kind of increase throughput. And so you're seeing 5 times the average number of patients, right? Is that what you said?
Yeah, I'm saying 80 to 100 patients per day, with me being in the room for less than 5 minutes, because we measure everything. It's a part of the last protocol craft, the throughput measurement. It seems like I'm really not doing a job of a doctor. How can you do 5-minute appointments? But if it's all stripped from things you don't have to do, then that visit, that 5 minute, is suddenly not a short visit. It's a visit where you're actually interacting with the patient naturally, where you don't spend time reviewing and checking and digging in the chart. If everything's done for me by my nursing team, my prepping team, that 5 minutes is actually meaningful. Like yesterday, I left the room saying, I was there for so long. I counseled. I looked at my timer. It was 11 minutes. I mean, oh my goodness. When was the last time I spent 11 minutes with that patient? It felt like forever for both of us. We connected. It was really, we talked about multiple things. So 5 minutes a regular visit, including counseling and complex patients, when everything's taken away that doctors doesn't have to do, it's actually more than most doctors think.
And so how many more staff do you think you have than the average family doc? Is it twice as much, or is it the same number of staff? Like, or is it 3 times? Like, how does that work?
I think an average model is one doctor has one secretary, and I know doctors who are married, like a wife and a husband together in the office, and they usually share a secretary. So it's either half to one secretary per doctor. That the model I'm seeing here. I have three secretaries and three nurses just for me, and that seems like what are you, how are you getting this paid? How is who pays for it? And the answer is my increased throughput funds them with an ROI of $2.1 spent on every dollar I'm spending. So that's the secret to this. And I could cut them down to say if I fire them tomorrow, I just would have to do cut
A
my
lot.
cut my volume in like a quarter and have my appointments which are available now tomorrow. You can see me tomorrow. Everything's open. I can fit anybody in. There's never a problem. And I would just have to cut down the volume. My availability for the patients will drop. And it's just doable, but it will be a proof of how what I've built so far would not work if you take away the staff.
Yeah. And so, how do you find the staff? Like, oftentimes it's difficult in private practice to find reliable folks who are medical assistants and nurses. And it sounds like you're giving them more work to do, or at least hire,
Yeah.
more, they have to follow protocols. They really have to work at the top of their license. Do you have difficulty finding these people?
No, we just had to hire a secretary because I had another medical building. I had equity and I was managing this for a little bit. So for the secretary staff, it isn't so challenging because they typically do their regular things that they requested. Everybody would request from them. But for the nursing slash rooming team, it's way more than they ever done. Now, my thought is to look for, because I have two nurses that worked in the hospital environment and one nurse that worked in urgent care, my first nurse, and she's just way more fast with patient processing. And the other two nurses are very good, and they actually help me with counseling. They're very patients love them and they're very sensitive, but they don't tend to be so fast and so well organized. And if there was my observation, what I learned is I would look for someone from like urgent care, walking clinic setting that they used to a pace and a fast movement, and then they just always the same thing. You look for someone who's teachable, who wants to learn, who's excited to switch and feel elevated with the extra responsibilities that you wouldn't usually belong to a nurse, rather than scared by them. And then the key is to be, a team leader where you communicate. It's not just dumping a set of guardrails or rules on the team. Is just being available, having the regular team meets. Every week we meet and say, hey, what went wrong this week? Is there anything I can do for you better? And I tell you what I saw from your end. And that kind of constant honing up of a relationship and showing that I'm supportive of them and that they never thrown in on their own. I think it's the big piece there. Yeah.
I love it. What about the physical design? How does the space look so that you're able to move as quickly? I mean, this has got to be like a ballet of getting patients in and getting them roomed and getting them ready. And then after you decide what needs to happen to make that all happen and check them out, have you gone through, various designs, or it's like pretty standard?
Yeah, so that's a good question. A year ago I moved to an office that I designed for myself. I use 7 rooms for myself, plus 2 procedure rooms if I have to. And it's all was designed with a thought of efficiency. If I come back to the craft manuscript, C is for the first clean, the things that are little throughput. Then you have the R for release. Then A is assemble your team. Then F is for flow. So the flow part of the craft framework includes organizing your physical space while your team is already assembled and running for you. If I was in this 4 room office before, I realized we limited by geometry. So we moved to a place that allowed us to be more efficient with more rooms. My ideal day is when actually I have 100% flow, where my prepping team prepares everybody and me, leaves me a message on the door that they're ready for me, and in specific order I walk in, and I can communicate. We communicate through the electronic kind of system we have built for ourselves, and that allows us to move along. They know where to go next. I know where to go next. It allows handoffs between the teams, and everything is based on like a fishbowl. Like ICU style where there's a central station where there's two computers for the nurses and two other computers for the doctors. And we move on from this central place to see all the rooms. We don't travel much and we keep on walking short distances and everything's available. No one goes to the room. I don't go to my office to type notes because I'm with them and if they want to ask me a question, I'm there. So the design is more of like a fishbowl ICU style. That's kind of really what's been helping a lot.
I love it. So talk about that. You said that you've designed an electronic kind of queuing system to tell you where to go and what to do. And I think you've named it DoctorFlow. So tell us about DoctorFlow. How did that come about and how's it work?
Yeah, so that's a system that we're in need of something different than when we used in our first two offices flags on doors. Next, who goes next where some people I know created some sort of like an electronic green red light. They built it for themselves, and then I realized I need something more reliable with being able to get more signals there. So I realized why don't we use a tablet on the doors and then have someone design a software that would allow every room to have a status. And by pressing in, you say what team members in what room. And when patients are in room, the order will be kept. So my nursing team goes in order. And when they leave me in order. And if we want to hand between each other, they let me just know on a tap so I don't have to look for anybody. It helps those handoffs and increases efficiency. So I hired an engineer on Fiverr a year and a half ago for $250, and he designed me the first prototype, which I used in my office for the first 6 months. And then someone noticed it and said, "Hey, what is this? Who built this?" I use it. It's mine. And then someone thought, you know what? This is something you could consider like selling to other people. And then I realized, I mean, I dismissed it at the beginning, but then I realized maybe it's not a bad idea. And I embarked on this journey of building it for others, which actually made me realize how complex that is, how many aspects of business of promoting and building a code that replicates, that has separate accounts, how to do marketing, how to do sales. Everything just was unrevealing in front of my eyes, and I didn't realize it was so complex. So now we're quite advanced on the journey. We have 7 clinics that use it, and a few others are signing up. So it's been going well. But I just want to say that it was very humbling to not know how much is there to learn to have a product.
Yeah, it's always easy from the cheap seats, and then you have to go do it. Well, that's great. We will definitely include a link in the show notes so that people can look for it and see how it works. And I just love it that you kind of just created something for yourself for very little money and just was like, well, let's see if it works. It would be great. If not, I didn't spend very much time or energy on it, and it's worked. And then I love the lessons that you're learning. Hey, it works great. It doesn't need to be tweaked at all until you encounter other people's workflow or the kinds of patients that they're saying. You're like, okay, maybe it does. Let me ask you this: just one thing, and we've talked about efficiency, and we've talked about how important it is to kind of take all the work that you don't absolutely need to do, you could send to someone else who's skilled and is within these guardrails of doing. One thing that we talked about when we were preparing for this talk was you said that your nurse peels the Band-Aid for you.
Yes.
And I think you mentioned this as a one-off, and I want to focus on it a little bit.
Yes,
How does that help?
Maybe that defines me. How I kind of how I want to just delegate the slightest things that don't feel comfortable for me, like the slightest rock in my shoe. I realize, oh, do I really have to walk with this rock in my shoe? Can I just give it to somebody? And that's one of the ideas. I realized that the Band-Aids, because I use a lot of joint injections, local doctors refer to me to do about 40 to 50 joint injections as a consult service in addition to my practice. And we have lots of room. You see me next week for that. So I realized that if I'm in a room, my knee injection takes me less than a minute, but peeling the Band-Aid takes me about 10 seconds sometimes from the outer white layer, before you get to the bottom white parts and the top brown one. So there's my main nurse is like once every few weeks, she just sits to all the Band-Aids and peels them, peels. Looks like she's peeling a potato, but she's peeling Band-Aids. And then she just distributes it in every room. So every room has Band-Aids that is peeled. I think that's, that defines how I just don't want to do stuff that don't belong to me.
Yeah, well, it's you could say it that way, or I think that just talks about the level of detail that you want to get down to, and how it actually 10 seconds here and 10 seconds there actually does contribute to you seeing us. I mean, 4 to 5 times what the normal family doc is seeing, number of patients at least, and still being able to get out early, and all your documentation is done and all of that. So it's amazing what you've kind of built for yourself, and I'm fascinated by watching what happens when you try to make some of these ideas more global, and see if doctors will adopt them, not only for themselves, right? Because you said, hey, this is financially makes a lot of sense, but also it's kind of unbelievable that you're telling me that I could call you up this morning and see you this afternoon. And that's a typical day. Like, your patients would be shocked if they called and couldn't be seen the same day.
No, this is true. If patients, there's some parts of the year where we get backed up, and there was a moment that my main manager said to me, "Say, we got to sit down. Patients are calling, and we don't have room for 1 week."
Oh,
And I said, "Oh, that's not good. Then what happened? So let's open up some more slots." But this was a real thing. It's like 1 week. That this is like, is the world like, what happened? Like, it's like, the sun is falling down from the skies on us. Like, it's a 1 week wait time for my patients. They get upset at us. So I said, okay, let's just open up extra afternoon slots, and we'll see them. So that's how my patients are used to it. Seeing me next day or in 2 days is usually very everyday thing.
yeah, that is not the experience that most of us have here in the US, either as as the provider or as a patient. Well, I could go on and on, but we have run out of time. And so I'm going to ask you the question that I always end with, and ask the same question, which is, what is something that is so well designed, kind of like your practice, that it brings you joy whenever you use it? Now, maybe I have an idea that you've already thought this through.
I was If I think of this, I won't be original. What comes to my mind first with such question is an iPhone.
Oh,
Because iPhone is this example of how everybody thought of phones for many, many years wrong way, with adding features, with making smaller buttons and more of the smaller buttons, with increasing security, with creating designs. But suddenly someone came, and I'm not trying to convince everybody that Apple's better than something else. It's not the idea about this. Someone just came and thought, well, let's make it usable. Let's put a user in the center so the experience is completely different. And that's what I'm thinking a lot about healthcare design, our tools in healthcare. We need someone to come and take those EMRs and rebuild them to that same extent where suddenly a doctor would feel like it's built from the usability standpoint, not as a bunch of cluttered feature lists put together somehow. And we all feel that it's just not intuitive to use. I think that's what medicine needs.
all right. So iPhone. I was gonna go with DoctorFlow. I thought you were gonna tell me about this amazing product that you do use though every day, and it does bring you joy. All right. Well, it has been a pleasure speaking with you today. I've learned a lot. I look forward to some of your non-conventional ideas, yet brilliant ideas, getting out into the universe and finding, giving doctors more and more ways of maybe improving access, and also improving their daily lives, and maybe even improving the bottom line. So awesome. Thank you. I look forward to kind of seeing when you take over the world. And I want you to think positively of me when you are in charge of the world.
Thank you. It's been a pleasure. Thanks for having me.
Thanks for tuning in. We hope you enjoyed today's episode. For more on Dr. Bart Kaczmarek, follow him on LinkedIn, YouTube, or at DoctorFlow. Check back for more episodes of Designing for Health wherever you listen to podcasts, or on NordicGlobal.com. We'll see you again next time on Designing for Health. If you enjoyed this episode, please leave us a 5-star rating and a review. This helps others find the podcast as well.